I'm going to move on. That is the exercise, did result in, to my mind at least, an unresolved but fundamental ethical debate about a scenario in which a rising number of COVID patients overwhelmed the ability of hospitals to look after them and other non-COVID patients. The Secretary of State, that's Mr. Hancock, took the position that in this situation, he, rather than, say, the medical profession or the public, should ultimately decide who should live and who should die. And then you say, fortunately, of course, that dilemma never actually crystallised. Just before I ask you about this, to note that, is it right that the previous Secretary of State, or possibly a previous Secretary of State, but Jeremy Hunt, had taken a different view of this matter, had he not? I think it was connected to exercise Cygnus, which had happened some years before. He had taken the view, and this is in fact something that he spoke about in evidence in Module 1 of this inquiry, that decisions of this type ought to be reserved to clinical staff. Is that something you're aware of?
Yes, I've heard Jeremy Hunt say that, yes.
So there you are. I mean, he took one view, and you're saying in your statement that on the 12th of February, Mr. Hancock took a very different view. Did you have a view as to whether that was an appropriate line for him to take, desirable or not?
I thought it would be highly undesirable other than in the most extreme circumstances, and you can argue that these are the most extreme circumstances, and that is one of the reasons why the Department of Health and Social Care, I think, created a ethical and moral advisory panel to sort of ask the question, if absolute disaster strikes, then how would you ration care, limit it in a way that would be fairest and have the, be the most defensible under this, horrible situation. But I certainly wanted to discourage the idea that an individual Secretary of State, other than in the most exceptional circumstances, should be deciding how care would be provided. I felt that we are well served by the medical profession in consultation with patients to the greatest extent possible making those kinds of decisions.
And is it something, to your mind, that was apparent earlier, or at least should have been considered earlier?
I think it was clear that if the reasonable worst case scenario were to come about in the UK, then the NHS would be overwhelmed. And we had a group of our clinicians and analysts working, for example, intensely with the SPI-M modelers on Sunday, the 1st of March, to refine what the parameters might be for thinking about how many intensive care beds each sick patient might need and so forth. And that produced a set of scenarios that evening, Sunday the 2nd of March. SAGE papers, as I see them now on the 3rd of March 2020, have two separate papers, one from Imperial, one from the London School of Hygiene and Tropical Medicine. SAGE on the 3rd of March says three things. It says it is highly likely there is sustained transmission of COVID-19 in the UK at present. Secondly, they say, given current surveillance systems, it will not be possible to time the start of interventions optimally. And third, they say, whatever the exact figure, NHS demand will greatly exceed supply in a reasonable worst-case scenario, even with behavioural interventions and behavioural and social interventions. So I think it is apparent that certainly by the beginning of March, it could be seen that if action was not taken to reduce the growth of COVID, then the NHS would be overwhelmed.